enjoying yourself?
I'm good. I'm good. Well rested because I was in the bed early,
Oh,
early
good.
yesterday. I did that actually twice. Um, uh, Wednesday, I think I was in the bed by 6:30.
Oh, wow. Well, you get up early,
But
so.
of course I got up at 3, like, okay, let's go. I was like, no, no, I need my couple of hours. Yeah, I do. I rise. My alarm, the first alarm goes off. Sometimes I beat it at 5. So yeah.
Wow.
Then I try to have my feet on the floor no later than 6 o'clock. Keep it moving. You're like, wow. Well, the weekends, it's about 6:30.
Oh, oh.
So I've been up for a while.
Can, can I tell I have never been a morning person. I think that's why, the good Lord pushed me into being a nurse because the best thing they could have ever invented was 3 to 11 and 11 to 7.
Oh, wow. Wow. I don't know. I used to, back in school, I could hit them all-nighters and when I went to school this last time, I was like, I can't do this. No. So what I do is I would get up early. Like I'll go to bed and then I'll get up like 2. And then I'll knock it out like for those few hours before I'm supposed to get up. And
Uh,
that worked better. But I'd be looking at stuff, cross-eyed, nodding out, head falling down. Like, what is happening? I cannot do this anymore. Buttercup, you are not 20. Far from it. But how was your week? How was your week?
it was busy because I'm in employment purgatory doing all these interviews.
I don't know, but I heard everybody keeps saying, I've heard several times about, and I'm sure your sources and stuff are coming from various other places. But somebody need to check in on the people over there in Indeed. They're like, some of their stuff is bogus, not right. People getting ghosted, nobody is responding, and all kinds of stuff is happening. Like, are they real ads, or has the bots got them and taken over, and it's an AI thing, or what? So be careful.
Oh, absolutely. But what I try to do with Indeed now, I do use Indeed as a resource, but what I have found helpful or the most responsive is when people when employers reach out to you from Indeed.
Okay.
Those
Yeah.
are pretty solid
Oh,
because it's
absolutely.
a person.
Yes. Yes. Absolutely. Okay. All right. Well, let's get this party started, huh? Well, welcome to our Saturday morning tea. Here we brew up the hottest topics in healthcare. We discuss health information news, education, certification tips, entrepreneurship, late nights, early mornings, job searching, and Indeed bots, all of the things. But we focus primarily on the revenue cycle at large and all that entails. And as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner. I'm the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. And let me ask, it's 2025. Prayerfully, you know these things. But if not, do you know what it takes to be a certified marketable medical coder? Well, before I introduce my co host, let me share with you information on a free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Hey, If you're interested in getting more information about the 5 steps to become a certified marketable medical coder, we'll check out the video description for the link. So joining me today is my partner in success. I love that line. My co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Well, before I introduce myself, I wanted to
Okay.
piggyback off what you said, Clarice, about because being a certified marketable medical coder now does not just apply to entry level. Like
Mm-mm.
you have to know that even if you have experience, because the way the industry is changing now, you have got to know how to keep up.
Mm-hmm. Absolutely, absolutely. I might change the steps from 5 to 10 the way we going. May make some additions.
Exactly. So, good morning, everybody. My name is Jesse. I live in Philadelphia. I have been in healthcare for a long time. I transitioned away from the bedside into HIM in 2014. And in 2020, I created a company called the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
Yes. And how is that going?
It's going along fine. I have a class and currently, and they are, overwhelmed right now.
But worth every second.
Yeah.
It happens. The first day of class jitters and you come in, and depending on who you are and how you coming in, sometimes you come in thinking, well, I don't even know why I'm here because I know all of this, but then you quickly learn and realize maybe you don't. Maybe there's some things I can learn.
Absolutely.
Hey, all right, all right. So let's see who's with us. Good morning. I don't want to butcher her name again.
Noemi.
Noemi. Thank you. Good morning. And good morning, LinkedIn user. Good morning, Tanika. Good morning, good morning. And good morning, Marie. All
Good
right, all
morning,
right. She
Marie.
said, hey, just learned about Jesse in the last 3 days in today's live. Look at God. Look at God. Uh-oh. Wait
All
a
right.
minute. She one of my people, huh? Look at God.
Good morning, everybody.
Oh,
Did you have a class? Oh,
is it a class?
do you have a class in A&R?
Oh,
Um, I
I
don't.
don't. I don't. But I bet you I know somebody who can get you what you need. I know somebody who can get you what you need, or on the
E-
spot correspondent. She can get you what you need.
exactly. Definitely.
We'll definitely have to have her connect with you.
Yes.
Definitely do that. All right, all right. So before we jump in, let me remind you that you can join in and add to the conversation. So don't be shy. Don't be shy. Your opinion matters and is welcomed here. So, friends, just use the chat as y'all see that y'all been doing all along. The only thing we ask is that you put a Q first if it's a question for us, so we know and we see it and we don't miss it. But if you're questioning or asking question amongst yourselves, feel free. Do what you do. We know how it works. All right. Like KCCCC, yes. We'll get you
Yes.
right.
Yeah. So all Noemi has to do is just either like reach out to me or Clarice, like send us an email, and we'll give you the crafty coders contact information.
Mm-hmm. Here's my email address if you want to grab that. Or I think our stuff, or I forgot how she's
Well,
on here
that's
through Facebook or through she's on here through, let me go back to my comments. Oh yeah, you on here through YouTube. So yeah, all the stuff is in YouTube in the description. So yes, yes, yes. Good morning, Nikki. Good
yes.
morning. Good
Good
morning.
morning.
Welcome, welcome. All right, all right. So, whew, before we get started, well, let me just say, for those who are joining us or watching the replay, today we are talking a lot of things. So, we're talking about the HCC coding crisis and how things in the game really, really are about to change. If you didn't know, you better know. As well as 2025 HIPAA updates and this uh, managed Medicare Advantage settlement that popped off. We talked, I think, was it just last week? We talked about this huge, large settlement, and lo and behold, this week we have another one that's actually larger. So, oh yeah, we got a lot. We got a lot on our plate today. Okay, but first, let's get into our church announcements, shall we? Uh-oh. Who's on her job? Who is on her job? Who was on her job? Hey.
This is his weekend.
This is his weekend. I feel conflicted about everything, but this is his weekend, and that's how I'm focusing. This is his weekend. Hey. See, I couldn't find that one. I was looking for that.
I like that too.
Well, I'll send you this too. Hey. Yes. Yes. See, now I can't clap. I gotta get the double claps in. Yes. All right. So in today's church announcements, our church announcement actually comes from our on the street correspondent, the Crafty Coder. And y'all know United Healthcare Group has a new CEO after the untimely demise of the previous CEO. Let me turn this down some more. Okay. And his name is Andrew Whitty. And he says, healthcare has to, quote, function better, end quote. Okay. So this is an article she sent me from Becker's Payer Issues by Riley Wilson. And it says that the CEO is telling the world that United Health Group is committed to reducing prior authorizations and improving customer satisfaction on the company's first investor call since the murder of United Healthcare's previous CEO, Brian Thompson. So they had a call on the 16th, and he kind of buckled down and said, really, healthcare needs to function better. Said healthcare is in every country is complex and the solutions are not simple. But you should expect this company to continue to work at it, finding what is needed, developing solutions, bringing those solutions to scale, and making a positive impact on the lives of millions of people. Yeah. He also said he is working to make coverage and cost easier to understand, including by investing in technology to speed up approvals for Medicare Advantage patients and reducing the number of prior authorization it requires in Medicare Advantage. Said some of the work to speed up claims can be done by United Health Group alone, but some requires the industry and policymakers to come together. He said the company is encouraged, and that's in quotes, by efforts from the healthcare industry and regulators to address prior authorization. But he says ultimately reform will come at the system level. And the core fact is that price more than utilization drives system costs higher. So tackling that problem will require all parts of the system and policymakers to come together. So he said there's still a lot of work to be done, especially around customer dissatisfaction and simplifying claims and other processes that they have developed, but they're excited and trying to do what's necessary to get the work done. He said less than 1% of claims are ultimately rejected for a clinical reason, but other claims are held up before being approved. Standardization across the healthcare industry and investments in technology can help speed this up. I hear AI, and the company is engaging with heightened energy, and that's quote, to improve processes. So, yeah. Um, so they're excited. They want to get everything to do all of the things, and they gave a spiel about Mr. Thompson. Um, gave a little bit about his history and his passion for finding solutions and improving experiences. Um, so yeah. So yeah, they got a new CEO. He talking to the investors. He putting his plugs in. He's addressing all of the folks, and so we'll see.
The only thing I wanted to comment on is there's a line in there. It says, Mr. Whitty said United Health, the nation's largest insurer. The United Health is the nation's largest private insurer. The
Yeah,
largest
because we all
insurer
know is
is the
Medicare is the
federal
largest.
executive.
Absolutely. Absolutely. You're correct about that. So who is this? Riley, get your stuff together. No, I'm kidding. All right, all right. Well, that's all I have. Mr. Jesse, do you have any church announcements?
Yes, I do.
Oh, all right. Say it with your chest.
I have a new ICD-10 CM class that is forming, and it will begin on Wednesday, February 14th. So
All
for
right.
more information, visit thecodingnurse.com to learn more and to get in contact.
Okay, what did you do to your mic? Because you done went.
Oh, maybe I scooted back a little. I was rocking back and forth.
Hit me with that one more time.
Okay, so I have a new ICD-10 CM class forming on Wednesday, February 14th. And to find out more information, visit thecodingnurse.com to learn more and to get in contact with me.
All right, all right. Yes, yes. So that concludes our church announcements. Everybody can have a seat. No, I'm kidding. Let me get rid of the banner. All right, all right. So let's get into the tea. So let the tea spilling begin. So first, we're unpacking the significant HIPAA changes that are coming in 2025. And whether you know it or not, these updates will affect every. You said you're pre-waxing?
Preaching voice. You put it
Preaching.
correctly.
Oh, I'm like, oh, I'm like, wait a minute. um, these updates will affect every healthcare organization. So the biggest news is the proposed HIPAA security rule update was published January 6th, 2025. And it was a lot. It's a lot in there. But let's talk a little bit about some of the key requirements. And some of them kind of were dribbled out in a final rule at the end of last year, but they are solidifying the things here with this particular rule update. So there's a technology and infrastructure updates. So required technology, asset inventory, and network mapping every 12 months. So that's something that will have to happen. They're looking for folks to have vulnerability scans every 6 months. An annual penetration testing must occur, and then regular security audits. So they're not playing for real. We've had a lot of things happen as it relates to security and in those things in the technology world. And I guess they felt like we have to do all of this stuff. You need to do all this stuff. Let's protect people at all costs. Some of the cybersecurity measures include encryption of all EPHI, that's electronic personal health information, both at rest and in transit. So wherever it's stored and if you have to send it. Multi-factor authentication implementation. Multi-factor authentication actually drives me crazy, but I understand the purpose for it and the reason for it. Network segmentation requirements, enhanced patch management processes, and removal of unnecessary software. One critical point they mentioned is they're removing the distinction between required and addressable specifications. Everything is now mandatory with limited exceptions. They're not playing in
Oh,
these streets.
I think it's about time because,
Mhm.
I mean, at this point, probably all of us have had our medical information compromised.
Y'all get them emails and all of the things, and then you get the actual notices in the mail from folks and all of the things. So it's like, well, wait, well, who is this and what is this? And oh, I gotta change the password. Oh, I gotta get the insurance. I gotta do all of the things. It's a lot. It becomes a lot. Let me also mention that this information came from an article in the HIPAA journal from Steve Altler. Um, and all of our articles that we talk about today are posted in the description, the video description. All right. The other thing was reproductive healthcare privacy. So the privacy rule changes for reproductive health care effective June 2025 is there's now a new definition of reproductive health care that was added to HIPAA. Limitations on PHI disclosures related to reproductive care. There's a requirement for attestation before sharing reproductive health information. There's a new notice of privacy practices section required around reproductive health. And then the compliance deadline was, it says December 23rd, 2024. So I don't know if this was something that was part of the older piece, or that was a typo on their part. I don't know. But something about December 23rd is a compliance deadline. And then this is particularly important given the current healthcare landscape and the state by state variations in reproductive healthcare laws. And so we all know that states are doing some different types of things here recently, and this is one way that from the federal perspective that they will take some type of uh, charge in managing the security and the privacy of those particular patients. Another thing is,
But bef- is
mhm,
this is your other comment about pregnancy or
go ahead.
so? I think that this is going to be important, and I'm really for it because there are some states that even if women went to other states to have reproductive procedures, if the other state found out, they could press charges.
Hmm.
And I think that this is really really good because it protects people's reproductive health information, and they really don't. Um, I don't think they need to have access. So
Mm-mm.
this is good.
And I remember there was conversation around lawmakers in various states asking specific questions in the vein of research to obtain information about folks' reproductive health and looking to find if folks were having certain procedures that were illegal in their state and targeting the provider who may have also provided those procedures. And so hopefully this too will assist in that nightmare because it really was crazy. Crazy.
So we have a question.
I see. And she said,
Well, I think she's asking, are there any updates for HIPAA for gastroenterology?
not that I know. Not that was in this article. I didn't see anything specific in this article on, yeah, but if you're in a if the practice is a gastroenterology practice and they are a healthcare provider, then these HIPAA regulations apply to them. It applies to all, but they may not have anything specific for that specialty. But because of the federal landscape regarding reproductive health, I believe that is why this, reproductive health was kind of addressed, and they made specific mention to it. Okay. The part 2 regulation alignment. So, your part 2 CFR part or CFR 42 part 2 is around HIPAA for substance use disorders and behavioral health. And so they want to they're in two buckets. And so those types of providers actually have to make sure that they're following both HIPAA and the privacy regulations in part 2. So this new HIPAA regulation tries to align um, those regulations with HIPAA for those types of records. So patients can now give broad consent for treatment, payment, and operations. There's also an enhanced patient's rights, including accounting of disclosures. There's a new right to request restrictions. There is a prohibition, get it out, girl, prohibition on discrimination, as well as implementation of breach notification requirements. So those are the things that are happening there. And then here are a few things that are compliance challenges that if you are in the compliance suite of the world that may be keeping you up at night. The costs of implementing all of these new security measures. This might be part of the CFO's up at night problem as well too. And then the training requirements for staff. So you know that you also have to have um, annual training on HIPAA and their requirements. And so not only do you have to have your regular training, but then you have to make sure that you implement training when there are changes and things that come out that are new. Timeline challenges for implementation, integration with existing systems, and documentation updates that are needed. So, Mr. Jesse, did you have any additional uh, comments?
Not at this time.
Okay. So remember, these changes are reshaping healthcare privacy and security. One thing I want you to do is think about how is your organization preparing for this, and what are they doing? Are they sharing information with you all now? Have you been hearing the buzz? Feel free. You can. She started laughing. You can put it in the chat. That sounded like a whole meeting after the meeting, little thing right there, didn't it? But you can also, comment in the chat. Let us know what's happening in your organizations. Okay. Next, let's deep dive into this critical issue affecting HCC coding. Not in the pastor's voice, in the pastor's voice. This article was from Littman Education by Rose T. Dunn. And she
Not Rosie.
yes, Rosie has been writing articles. Well, she's always done that. And I think
Yeah.
she does some training on it as well. But she has talked about what is going on in the world of HCC. And it's the problem that's happening with coding from problem lists. And as soon as I saw that, my whole face just contorted. Like, what?
Exactly.
Why?
Exactly.
Why? So this isn't just about following rules. Again, it's about ensuring proper reimbursement and compliance. So the core issue is that there was a recent question that she received regarding, can we use problem lists for HCC documentation? And the short answer is no. No. And stop. No. I don't understand where that came from and why, but we'll talk more about that in a minute. But anyway, so CMS has been clear in their risk adjustment user group Q&A. Okay, I didn't know that that existed.
Me either.
Right. So that was a gem for me. So if you're a part of the HCC coding world, go and look for Google, it's your friend, the risk adjustment user group Q&A. Because they're talking and they're answering. um and it says that problem lists alone are not acceptable documentation. So think about it. A problem list could include any condition a person has ever had, whether or not they receive services for it during the data collection period. Okay. What's interesting is that even if your progress notes reference the problem list, that still is not enough. We all know what is needed for HCC coding. And go
Can
ahead.
I jump in for a second? But
Uh-huh.
the problem with that is we've all seen these long problem lists in these charts. But what happens is with AI, all they do is if they see a diagnosis, they flag it. So you have to. It just creates more work.
Hmm.
But
For everybody.
But this is coming from AI.
For everybody. Well, prior to AI, folks especially in certain EHR programs, software, folks were automatically uploading or having their problem list uploaded into their assessment, which was driving me absolutely crazy.
That's crazy. Mm-hmm.
And they were doing it on a regular basis. So physicians were or providers were under the impression, maybe, I guess, that this is a chronic patient. I see this patient all the time. I see this patient for the same thing. Well, we'll just upload this have the problem list come over in the assessment. And oftentimes things will get missed. So they may only provide information about a couple of things. So it was difficult to determine whether or not this was something that actually met the meet criteria. Oftentimes it did not, because it was just something I didn't even see that because they weren't here for this, or I didn't touch that. So having those EHRs automatically upload the problem list in assessments needs to go away immediately. And or if they're using these AI bots to do things, then they need to train the AI bots on what is appropriate and what is not for when they're looking for keywords or key phrases or what have you in this documentation. But let's talk a little bit again about what we actually need for proper HCC documentation. And we talked about this over and over again. I think Mr. Jesse even got blue in the face one day. We were talking about meat. And meet means monitor, evaluate, assess or address, and treat. So those are the things that you're looking for the diagnoses for that date of service during that time, for that data service, or during the time frame that you are in your um, collection period for documentation that needs to be documented by that provider. So let's break those down. Monitoring means tracking signs, symptoms, disease progression, or regression. For example, documenting blood pressure remains elevated or A1C trending down. So you have to provide the documentation to show that you did monitor. You're tracking things. You're looking at the disease progression or regression from one time period to the next time period. Evaluation involves looking at test results, medication effectiveness, and response to treatment, like noting statin therapy showing positive results with LDL now at goal. Again, that type of documentation is explaining and showing that an evaluation has actually occurred regarding that problem. Assessment or addressing includes ordering tests, having discussions, reviewing records, or counseling patients. Think ordered comprehensive metabolic panel or discuss dietary modifications. Those are the types of things that the providers need to be documenting related to that. Treatment covers medications, therapies, and other modalities. For example, increased metformin dosage or referred to physical therapy. Again, this is documenting the actual treatment for that diagnosis. Remember, if they have multiple diagnoses, then you need to have some meat on them all to show that those things were addressed at that encounter. Also, recent feedback suggests that some auditors, whether they are in the managed care or managed Medicare Advantage world or not, but some auditors are actually looking for all four meat elements, not just one. So somewhere, somehow, I don't know. So take note of that. And that will be a significant shift in expectations, but better to be safe than sorry.
But how could you get all four in one encounter?
Sir, I'm providing the news.
Okay.
You can document.
But all four, you don't, because if somebody has a chronic condition and you're monitoring their labs, what else do you need to do? Like, what else needs to be documented? Like, because it's one of the four. It's not all four.
And so I think while this addresses the diagnosis for your HCC coding, this is actually practical guidance to assist in documenting your medical decision making for your evaluation and management service, which clearly can be documented using all of these things. It's a hand in hand. It's a hand in hand.
But we're talking about chronic conditions, so a chronic condition is not won't be necessarily be. And if they came for a follow up for a chronic condition, then fine. But if they're just randomly mentioned in their A1C, but they're there because they have chest pain, that's going to be your medical decision making. Like, you're going to clearly know from the documentation why the person is there.
Exactly.
So I don't. So why would you need all four elements? That's my question. Like, it doesn't make sense.
Okay. And you can divert your question to the risk adjustment. No, okay. No, but currently today, you're right. There isn't any stated requirement that all four are needed. However, again, based on this documentation and this article, there are auditors that are actually stating they want to see all four documented for those conditions that they are counting for HCC. So that's just something to think about.
But who's gonna push back, because all this is going to do now. If I were a provider, I would lose my mind, because why would you have to document all four elements for every condition you document? Like, that's going to be a lot of documentation, and they don't even want to document appropriately for one thing.
I understand.
I just
the burden will be coming out again. You'll be hearing more and more about the quote unquote documentation burden of providers. But it'll be interesting to see where we land and where it lives.
Because I have never understood, and I always share. I started out in risk adjustment in 2014.
Mm-hmm.
It is the easiest coding I've ever done.
Mm-hmm.
It is not hard. People make it hard with all this foolishness, and nobody ever really puts it where it really needs to be. The problem in risk adjustment period, well, in coding period, is always documentation.
Mm-hmm. And that's what you got. That's what you're doing your job based on what it is that you receive. That's the
right. And they try, and the reason for the problem, the reason why they go back and forth with the problem list forever, is because they try to capture as many HCCs as possible. But you still have to have, at the end of the day, for every diagnosis, you have to have clinical support, period.
Mm-hmm.
It doesn't matter that somebody had an embolism in 1972. Do they have an embolism now?
Correct. And again, from the provider perspective, and again, I'm speaking to documentation for the actual service that they're providing. So if it's an evaluation and management service, that rule still applies. You also have to make sure there is documentation to support in order for you to get credit for the medical decision making and that level of service that you are claiming. And so again, for me, this meet matches all of the things that are looked at for evaluation and management service leveling. So those things would need to be documented for those diagnoses to count to get them to a particular level of service that they are claiming they have provided.
Right, but
If you look on that, if you look from that perspective.
right, but they've been doing it. I mean, meat is not new. I mean, medical,
Yeah.
you know, E&M isn't. I mean, they've been coding E&M. All these visits have an E&M attached to them, and it hasn't been and even with everything comes down to documentation.
Mhm.
I'm just saying, I just don't think you need to have all four. And these auditors, whoever came up with that, they get ready to get shut down because that's not going to fly. And especially in inpatient with all them daggone specialties documenting. Oh no, it's not going to happen.
Mm-mm. Well, we'll stay tuned. So let's see, what does this mean for your daily coding practice? So when you see a problem list, consider it a roadmap, not documentation. Again, each condition needs to be actively addressed in the encounter note, not just something that you list from a problem list. And so a real world example looks like if diabetes is on the problem list, but the provider only writes diabetes stable in the note, that's not enough. They need to see elements like review the blood sugar logs, the A1C improved to 7.1, continuing current medication regimen, counseled on diet. So you need to have additional documentation to support that you provided um, the meat on the particular diagnosis that is
Now
listed.
I agree with that.
So here are some key takeaways for ensuring compliant documentation. Again, our documentation is what we receive from the provider. So the providers need to be trained on actively documenting their thought process for each chronic condition. Implement templates that prompt for meat elements, regular audits of documentation against claimed HCC codes, and again, don't rely on automated pulling of problem lists into notes. That part just drives me crazy. I wish you would stop, 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 stop. And if you keep playing, you'll end up like this. So, we're also talking about this historic $100 million Medicare Advantage settlement. This case is groundbreaking for several reasons. And so let's look into what was going on. So the settlement, or the Department of Justice, announced a settlement with Independent Health, a Medicare Advantage plan in upstate New York. And here's what makes this case remarkable. It's the largest ever Part C settlement based purely on a whistleblower case. The settlement amount is up to $100 million. It includes a $2 million personal payment from a vendor executive. They looking at the vendors, y'all. This is
That's
the
what
second one.
I was
This is
waiting
the
because I'm
second
like,
one. This
mhm.
is the second one. They're looking at the vendors. The case took 12 years to resolve. So there was a lot of stuff that they had to go through. And the whistleblower will receive up to $22.5 million. But again, it's not just about the money, it's about
No,
accountability and
no.
the future of risk adjustment practices. So, the whistleblower, who is Teresa Ross, was a former director of risk adjustment at Group Health Cooperative. What's fascinating is that she wore a wire to support the government's investigation. As soon as I saw that, all I could think about was Bad Boys when they had the girl walk into the water to make sure if she got on the wire or not that they could talk. They're gonna have everybody we being pat down for wires. But anyway, um, The common thread between this case and an earlier 6.4 million settlement with Group Health Cooperative is the vendor DXID and its CEO Betsy Gaffney. Both organizations use DXID's services for chart review and risk adjustment. So let's talk about why this matters for Medicare Advantage plans and providers. The case highlights issues with contingency fee arrangements and risk adjustment. It demonstrates the Department of Justice's focus on individual executive liability. The settlement addresses the practice of retrospective diagnosis additions. It reveals problems with asking doctors to sign forms adding diagnoses up to a year after patient visits. And then the case underscores the importance of proper documentation and coding practices. This settlement is part of a larger pattern of enforcement actions targeting risk adjustment practices in Medicare Advantage. And so this settlement sends kind of a clear message to the industry. Vendors and executives can be held personally liable. We're seeing that. This is at least the second one that's been brought to my attention. Contingency fee arrangements will face scrutiny. Retrospective diagnosis additions need careful oversight. Documentation timing and authenticity matter. And whistleblowers play a crucial role in law enforcement. Mr. Jesse, any thoughts? Other
Yeah.
than you should have been the whistleblower. No kidding.
So I think, well, actually, there were two places where I should have been a whistleblower. I have just never understood. Well, I do know. Let me know. So a lot of these companies outsource their risk adjustment to companies. And these companies are incentivized to find additional HCCs. So that's really where all this comes from. It's just greed. And they play in the gray area because if you hire somebody to do work and those people come back with recommendations, you're going to think, okay, well, as a company, this is what I paid you to do, so I'm going to implement what you said implement. Now, if I get, hung up or caught up as a result, then you have to bear some of the responsibility, or actually most of it. And I totally agree with that. But risk adjustment is not hard. It really is not. I mean, it is very clear. Like, the government provides a list of codes that risk adjust point blank. They also provide an Excel spreadsheet for you to check to see if the code is on the list point blank. When you put that code on that, when you code that particular code, you should have already gone through the meet process. So you shouldn't be putting down something that wasn't validated.
Correct.
So I don't understand. Well, I do understand, because for number one, the production for HCC coding is ridiculous now.
Really?
It's ridiculous. So people can't do a thorough deep dive to really accurately check what's going on. I mean, if it's like if it's like a visit, that's kind of simple. But even a visit doesn't really capture everything, because very few people go strictly to their PCP, especially for chronic conditions. People who have chronic conditions have specialists that they see aside from their PCP. So you have to look through the system for specialist notes. You have to look to see, where is this person being seen for oncology? Where is this person being seen for rheumatology? Where is this person being seen for cardiology? So you have to look and see, and also the government provides a list of their problematic cases, their problematic codes. All you have to do is, if you are doing this, all you have to do is have a system in place that when certain codes come up, they're automatically flagged for a more thorough review to make sure that you have meat. But once again, it goes back to the oncology notes, because you'll have a doctor, I've seen it, you'll have a PCP write breast cancer. They don't say history of.
They don't say nothing.
Then they
And so
say
you're
breast
thinking,
cancer. Then they'll say followed by oncology, or follow. But then when you look at an oncology note, if you can find one, The person had treatment last year. That was the last time they had treatment, last February. That is not active.
Correct. Correct.
But
And so
it
you
takes
can't count that towards your ACC.
but it takes time to find that information. And they want these crazy production because they think it's volume, but it's not quantity, it's quality.
Absolutely. And
But
that's
they
what the coding should that should always lead with any type of coding that is being done. And unfortunately,
they don't get
these
it.
organizations, right, and they're looking for quantity in dollars, and you know, when they could save a lot of money by making sure things are done appropriately on the front end versus all of the different folks and people that then have to touch it on the back end in order to correct them. And or if you then get into an audit situation where unfortunately you're going to pay out even more money. So do the right thing on the front end. How about that?
And then
Looking.
also it's just one more, just last thing. And then it's also is poor training
Mhm.
because they have too many people in these positions who don't know jack. How can you be a supervisor, a risk adjustment supervisor? You never code a risk adjustment. What are you doing? Who can I ask if I can't?
Managing people? No, okay.
This is not little league,
Sir. These are people's lives. This is
and it's
documentation. This is
money.
reimbursement. I just wanted to level set because I know I don't want to talk over somebody who may just be new and not understanding specifically what this really means. So, Advantage is a Medicare alternative system to traditional Medicare. And so the government partners with private insurers and pays them a premium to cover the Medicare beneficiaries. The premium payment is generally higher if the beneficiaries have more documented health conditions. That's why it's more advantageous to have multiple diagnoses or multiple conditions, chronic conditions that are being actively treated. So, as a result, there is an incentive to make patients appear sicker than they are in order to increase their risk adjustment factor or RAF score. So they're getting scores based on, and to Mr. Jesse's point, all that information is on that spreadsheet that the government puts out. So you know what the RAF scores are. You know how to play the game, if you will. However, your documentation has to support whatever the game is that you're trying to play. And if it doesn't, that's where you get into problems. And then that's where you are subject to what is known as risk adjustment fraud. So, and then Medicare sets up specific rules for medical record documentation and sourcing. And again, these folks that were part of this particular um, uh, case got caught up with all of the things. Yes, yes, yes.
And Medicare Advantage is becoming such a hot potato that a lot of insurance plans are starting to cancel their Medicare Advantage. And I don't blame them. If you can't do it right, then don't do it at all.
Don't do it at all. That should be the theme for 2025. You can't do it right. And it's okay. You have established a certain type of business, you've established a certain reputation for the business that you're doing. If you can't do that, it's okay. Just because Johnny doing it don't mean you got to do it too. Do what you know. Focus on what you do and aim in excellence around those things. That's a word right there. That is shown enough a
Yeah.
word for a lot of folks. All right. Any final thoughts on these articles, Mr. Jesse?
No, but I just would just say for the coders involved in any type of coding, it is really on you to know how to code compliantly.
Mm-hmm.
The burden is on you. You cannot rely on a company. You cannot rely on a supervisor sadly, to guide you. Like you have to really take the time to invest in your continuing education. And you have these forums now. You just have to hope and pray that you ask a question and somebody has some sense that can guide you. And you always want to research on your own to make sure that the information you have is accurate. The
Absolutely.
burden is really on the coders now because you really have no help out here, and it's sad.
And that's a part of what makes you a certified marketable. Let me pull out the marketable medical coder. All right, all right, all right. Good information today. Good information. Let's see. Let's see. Do-do-do. Yeah. Okay. Thirsty for fresh perspectives on the healthcare revenue cycle? Well, by becoming one of the PRNT sippers, you'll join a community of sharp minds who savor the complexities of the healthcare revenue cycle. So, why sip alone when you can steep in knowledge together? Come, let's spill the tea on industry insights. So, what you can expect as a valued member of the Tea Sippers: exclusive healthcare insights, gain access to in depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, and revenue cycle best practices. Early access: be the first to receive expert insights and guides, ensuring you stay ahead in the ever evolving healthcare industry. Personalized support: enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. And then my favorite, the community connection. So join a private community of healthcare professionals where you can network, share experiences, and collaborate on finding solutions to common challenges. So by supporting us, you're not only advancing your healthcare knowledge and career, but also contributing to the success of the Professional Reimbursement Network LLC, a resource that empowers healthcare professionals like you to thrive in their roles, goals, and dreams. So thank you for considering becoming a member of the Tea Sippers. For the cost of 2 cups of tea, you can join the community. Check out the link in the description of the video. You can also go to bit.ly/ the PRN Tea Sippers to get more information. Your support means the world to us, and we look forward to helping you excel in the world of health information and healthcare revenue cycle. I swear I'm gonna make my commercial. I am. All right, y'all. Well, thank you again for joining the Saturday morning tea or checking out the replay. Let me ask you, was the tea spilled today? Put your teacups in the chat. Let us know if you got something in one of these articles. Did you learn something? Again, I learned about a whole Q&A that I need to be, y'all looking in forums. I'm going to Q&As to see what's what's happening.
Absolutely.
Now, before we sign off, I've got a special request for all you amazing viewers out there. If you found this episode helpful, don't keep it to yourself. Share the knowledge with your colleagues or even your frenemies by hitting that share button. And hey, why not subscribe to our channel while you are at it? That way, you'll never miss a drop of our health information, compliance, revenue cycle, and medical coding tea. Got thoughts, questions, or experiences that you want to share about today's topics? Well, we'd love to hear from you. So drop a comment below and let's keep the conversation brewing. And if you enjoyed this episode, give it a thumbs up. It helps more healthcare professionals find our content. Also, check out the Coding Nurse channel on YouTube and visit his website, thecodingnurse.com, to get more information on classes and programs and him. You get all the things, uh, the Coding Nurse, all the things. Remember, on the Saturday Morning Tea, we're all about building a community of savvy, informed healthcare professionals who are certified and marketable. So, like, share, subscribe, and comment, and let's grow this community together. Mr. Jesse, do you have any final thoughts for today?
No, I think we covered a whole lot of territory this morning. It
Yes,
was
we
good.
did. Yes, we did. After last week, boy, we was like, woo. But this week was good. But however, it's still some food for thought. Still food for
Yeah.
thought. And making sure, and I think you hit it on the head. We are responsible for what we produce. Yes, we are relying on others and their documentation, but ultimately, a buck stop with us. And if we see things that doesn't look right, doesn't sound right, doesn't smell right, then it's up to us to make sure that we're checking and providing information to others who may be in positions that can make certain decisions on correcting those things. So, yes, tell a friend, tell a friend. Well, thank you, thank you. Glad you enjoy. Welcome, welcome
Yes,
for joining us.
likewise. Yes, thank you.
Yes. So again, this has been a great session today for you PRNT sippers. Remember, we have our meeting after the meeting at 10:15 a.m. So check your links over in Patreon. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great weekend.
Happy
And
MLK
happy,
Day.
right, I was just about to
Yes.
say, let's focus. Happy MLK Day. Let that be the focus. All righty.
All right.
Talk soon.
Bye bye.